Okay, so I'm just going to do a demonstration here on intubation. I am going to show you some of the supplies first and double check my supplies. Meanwhile, my partner is going to go ahead and ventilate the patient, so I'm going to insert an oral airway. Okay, and my partner's going to ventilate. And we're getting good chest rise for now. Assuming that we aren't getting good chest rise, or for some other reason that we need to intubate this patient, I'm going to go ahead and collect my supplies and double check everything. So I'm going to use for this patient a size 7 ET tube, remembering that ET tubes can be sized based on the size of the patient's finger. We also want to make sure that we have a stylet in the tube and that the stylet does not come out the end of the tube. It needs to be about a half an inch or so, a couple centimeters at least, back from the end of the tube. Okay. And then we're also going to double check and make sure that the cuff of the tube inflates well. So I'm going to go ahead and put about 5 to 10 milliliters of air in the cuff, and it does look like it's good. So we're going to go ahead and pull that back. Now I would also lubricate the tube in order to be able to use it. And of course this is all, we're maintaining a clean field here, so I would not be setting this directly on the table. I would have something to set it on. Okay, so that's ready. My partner's going to be ventilating for about 2 to 3 minutes. I'm going to double check my laryngoscope blade. I like to use a MAC blade. It's the somewhat rounded blade. Make sure that the light is white and bright and tight if you can tighten it. For example, on a Miller, on this Miller, you can see that the blade is here, and we might be able to tighten it there. There's another, we can look at it later, but there's another type. But I'm going to go ahead and use the MAC blade. This is a size 3. 3 is typical for adults. If you have a very large adult, you may end up using a 4. Anything less than a 3 is typically only used on kids or very small adults. I also have some capnography supplies here. So this would be the line that I would hook up to my monitor, and I would place this between my endotracheal tube and my my bag valve mask in order to be able to measure capnometry and be able to look at the waveform. I'm also I have here a colorimetric device that we can use to basically measure the presence or absence of carbon dioxide. And so it's not a super reliable tool, but if it's all you have, it's better than nothing for helping to detect proper endotracheal tube placement. So now that my partner has been ventilating the patient, oh, and I also have here a commercial device for attaching the ET tube. So now that my partner's been ventilating, I'm going to tell my partner that I'm ready to go ahead and intubate. And so I'm going to get my blade up, pull the oral airway out, make sure that my patient's head is back, insert my blade until I can see the airway. Now I do want to make sure that I'm not pressing on the teeth. So this guy's pretty stiff, so I have to use my forearm to hold him down. And I do want to visualize the vocal cords. Insert the tube until it's 1 to 2 centimeters past the end of the past the vocal cords, till the cuff is past. I'm going to inflate my cuff, hanging on to my tube, pull this syringe loose so that my cuff stays inflated, and I'm not going to let go of this tube. I'm going to note that the number on the tube is about 19, and I want to make sure that it stays there. My partner's going to go ahead and attach that. Sorry, we're going to go ahead and use a colorimetric device to attach here first. If I have the capno line ready to go, I might go ahead and attach it in place of a colorimetric device. And so now we're going to be checking for breath sounds. We're going to listen on both the left and right sides as well as over the epigastrum. We're listening for air sounds in the epigastrum to indicate that we have intubated the esophagus instead of the trachea. And if we hear no air sounds over the epigastrum and we hear bilateral equal breath sounds over the chest and we have equal chest rise, then we can go ahead and continue to ventilate the patient. Now I'm going to go ahead and have my partner switch out the colorimetric device with this capno line. And then we would actually hook this line up to the monitor, and that would give us the capnometry and capnography readings and waveforms so that we can actually tell how the patient is handling this. If we're getting good readings, which a normal reading is 35 to 45, then that would indicate that we continue to maintain a good endotracheal tube. So now that I've got everything in place and my patient's being ventilated, I'm going to go ahead and attach the commercial device. This one's made so it's going to work a little bit easier for me to do it this way. Now, our mannequin's teeth are pretty close together, so sometimes it's a little challenging to get the device down in where it needs to be. So I'm going to pull this out, and then we're just going to tighten this around the tube, making sure that this is all the way down, and making sure that we have here what we need. So now that this is all the way against the mouth and the tube is tight, I'm not so worried about losing control of the tube here. So this is just going to go under the head, except it doesn't want to stay in place. And you grab it on that side if you would. Okay, and then I can come up through here. The whole thing flipped over. And then we can tighten it down. And now my ET tube is in place, and I can continue to measure the effectiveness or the proper placement of the ET tube by monitoring the end-tidal capnography. And I think that's it. Did I forget anything?